Thank you again for joining us. It's a privilege as Vision Impact Institute to be hosting you today with prominent speakers from the World Health Organization, from Essilor, and from AFCO. We're excited to bring you the topic of global state of vision care with a focus on Africa, really diving into the World Report on Vision and the Eliminating Poor Vision report from Essilor. As we look at today, some of the housekeeping items, basically just keep those cameras off, keep the sound muted until the Q&A period. If you have chats that you need to send us with questions, if you prefer to send a question ahead, feel free to use the chat feature on the side and we will deal with those questions at the end. So it will be a quick introduction from me about the Vision Impact Institute. Some of you may not know who we are. I'll give you a quick rundown on who we are, and then we'll have opening remarks from Ayukatong, and the World Report on Vision will be presented by the WHO speakers. We'll have a discussion about the Eliminating Poor Vision in a Generation report from Essilor, and then we'll really discuss kind of the bridge between those two topics. What is the changing landscape of vision care in the context of the reports? Then we'll hold 30 minutes for a Q&A with you to discuss these two reports and whatever it is that you would like to hear from us on these topics. And then we'll close. So thank you again. There are more than 50 of you who joined us this morning or today. It's noontime your time. We appreciate your support and hope and trust that this will be a very pleasant experience going forward. I'll give you a quick introduction of the Vision Impact Institute. Obviously, the picture of me here looks better than what I look like at 5 in the morning. So thank you for your forgiveness on an early morning for me. The Vision Impact Institute, when we talk about this organization, is a global nonprofit organization. It was established in 2013 with the focus of the impact of poor vision and research around that topic. How do we really address the priority that is required within governments, within countries, with our priority leaders for the impact of poor vision on its population? Our mission is to raise awareness about the importance of vision correction and protection to make good vision a global priority. So one of the things that we do here is we take research on the impact of poor vision and we turn it into awareness campaigns, we turn it into advocacy efforts around the world. And then we have an asset pool that basically is an evidence-based awareness and advocacy resources. Our website is a very unique website with a database of 500 plus studies, unique studies that have been done on the impact of uncorrected vision. You can see from the next slide here that we have an independent advisory board that is a very prominent group of people. We have people from Johns Hopkins, we have London School of Hygiene and Tropical Medicine. We have someone who's an economic advisor in China and a manufacturing chairman in India. Professor at Brandeis University and top researcher, chief economist at the Global AIDS as a Global AIDS coordinator. And then Serge Resnikoff, who is also former WHO, an international expert and consultant in global public health. These are the people who ensure that the VII is staying consistent to its mission and allows us to have a bigger voice around the world. You can see at the bottom the executive team. Today on the call, we have the full team. And Eva Luzuka, you will see at the end of our executive team, is the representative, the director in Europe and Africa. So for when you have issues that you would like the VII to address, she would be your direct contact. I look forward to introducing all of you to her if you have not met her already. This morning, it's my privilege to turn the meeting over to Ayukatong. I want to say thank you most of all to the African Council of Optometry Public Health Committee for helping us to facilitate the meeting, for helping us to spread the word about the meeting. Thank you so much, Ayukatong, and the table is for you. I think muted.
Hello, Kristan, and hi, everybody. I'm so excited to be part of this wonderful webinar. The times are indeed very challenging, and I hope you and your loved ones are keeping safe. You know, as a Christian rallyist, I'm Enowtai, Nkongho, Ayukatong. I'm privileged to be the chair of African Council of Optometry Public Health Committee. I also double as a Secretary General of AFCO Board and privileged to be a member of the World Council of Optometry Public Health Committee and also one of the 3 African representatives at the World Council of Optometry. So this webinar is an opportunity for all of us. I want to thank SLO and I want to thank Vision Impact Institute for reaching out to us through Professor Kovin, which I give special thanks. This is an opportunity for us to, look into these 2 important documents. Now, we are voices to our various communities. Our people need quality eye care services with equity. Now, this World Vision report is more prescriptive than the previous one, like GAP2 for 2014-2019. My humble request would be that we should hold our seats tight, get the maximum best we can get from this, and go back to our people and see how we can bring them quality eye care. I know that there are systems that are being put in place so that we can get feedback from you, because it is a bottom-top kind of interaction. And I know that this partnership will help us to improve eye care services in Africa, and posterity will judge us for what we will do after this. It is a humble aspect from us that Africa is the first to host such a thing, and we pray that the impact should be felt, not just in Africa, but across the world. Wishing you all good health. Enjoy the session. Thank you very much. Over to you, Kristan. Hello, Kristan.
You are mute, Kristan.
Crazy time, sorry. I really appreciate, again, Ayukatong, your willingness to help us with this. I agree with you that it's definitely a clear time. When we originally talked about these 2 reports and how they would shift and change the vision landscape in 2020, we had no idea that we would be in the middle of a global pandemic. We believed that 2020 was the launching pad for a greater priority for vision care. And so one of the things that we want to ensure is that we don't fall behind on this. It still is a great year for us to continue to bring forward what it is that we will do in the future and how we will address the vision landscape going forward. So thank you very much. Our next speaker is Alarcos Cieza. She's the coordinator for blindness and deafness prevention, disability and rehabilitation at the WHO. She is going to also introduce you to another speaker. I'm going to stop sharing my screen so they can also share theirs. So please join Alarcos. Thank you.
Thank you, Kristan, and welcome to everyone to this meeting, also in name from the World Health Organization. It is a great pleasure for me and for my colleague, Stuart Kill, to be here with all of you today. The objectives now in the next about 20-25 minutes will be to share with you the content of the first ever World Report on Vision from WHO. The significance of this report, I think, rely on 3 important facts. The first one is that summarizes the best available evidence in terms of the global magnitude of eye conditions and vision impairment. And I want to put the accent that the report does not only concentrate on focus on vision impairment, but also on eye conditions and the evidence that is available here. And also in a way, you will see that has not been reported so far. The second significance of the World Report on Vision is that also takes a stock what are the areas where we have made progress in eye care globally, what have been the challenges that we have faced and that really we have addressed, but also what are still the challenges that are there and that really we need to come together and put our act together to address over the next 10 years. And thirdly, it also outlines a framework for action. What needs to be done from now on so that we can tackle the remaining challenges. And that is what we would like to especially discuss with all of you today. And the proposal of the World Report on Vision, as you will see, is integrated people-centered eye care. So if I'm asked to summarize the content of the report with one word, I would say is integration. So integration, integration, integration. One of the things that we have realized is that actually vision and eye care has been provided very often and in many countries of the world as a parallel separated system and not really integrated into health services, into general health service. And that this has been really a barrier in order for the eye care sector to advance and to achieve one of the most important things, that is that everyone in the world who needs eye care receive that eye care that is needed. So we need really to put our act together and then move forward in that direction. So with these opening remarks, I would like now to pass the floor, as I said, to my colleague, Kill, who has been also one of the main or the leading authors of the report. Stuart, back to you.
Thank you, Alarcos. And can you hear me okay?
We can hear you very well.
Yes. And you can see my slide here?
Yeah, we can see that. You can go.
Okay, fantastic. So thank you. It's very good to be with you all today. So I'll move on from Alarcos and first present on some of the good news over the last few decades. So obviously, considerable efforts have been made during the past 30 years to really address eye conditions and vision impairment, which has resulted in progress in a number of areas. First, we see, as you know, there's been global advocacy efforts, most notably Vision 2020, the right to sight, which really has been pivotal in achieving unified and coordinated advocacy for key priority areas for eye conditions and vision impairment, both at a global, regional and national level. Quite a few, 4 in total, World Health resolutions have been adopted during the last 3 decades to really maintain this momentum, and most notably that the most recent in 2013 that was accompanied by a global action plan, Universal Eye Health Global Action Plan, that actually ends, as you know, this year. So it's timely that the World Report on Vision can set the scene as on the way forward. In terms of progress in eye conditions, we've seen eye infections and blindness due to vitamin A deficiency, trachoma and onchocerciasis really substantially decrease in all regions due to the successful implementation of public health initiatives. And we've also seen significant increases in cataract surgery rates in many low and middle income countries. Scientific and technical advances play a big role in eye care, as you know, and particularly given eye care is a very highly image-driven profession, we see improvements in access to services, in diagnosis, management, and also in rehabilitation. So what are the key challenges? One of the key challenges is really the huge need for care. So as Alarcos mentioned previously, everyone, if they live long enough, will experience at least one eye condition in their lifetime that will require the appropriate care. So estimates of the number of people with eye conditions that can cause vision impairment and blindness really just highlight how common these conditions are. So we have nearly 200 million people with macular degeneration, 150 million with diabetic retinopathy, 75 million with glaucoma, and then we have the huge number of people with refractive error, largely driven by myopia and near vision impairment due to presbyopia. So the challenge is, and one of the key challenges is that the number of people with these conditions is going to significantly increase in the coming decades. So we have aging populations, we have population growth that's going to cause a notable increase in the number of people with macular degeneration, glaucoma, cataract, and other age-related eye conditions. We also have lifestyle factors such as diabetes. We're going to see a notable increase in the number of people with diabetes and diabetic retinopathy that require regular care. And also, as you know well, lifestyle factors of intensive near work activity and less time spent outdoor have been implicated in the significant increase in myopia over the coming decades. So really what this emphasises is that these demographic changes will have a profound impact on the already strained eye care health system and eye care workforce. What's also important to note, and what the World Report on Vision really brings to the floor, is not just to focus on those conditions that cause a vision impairment, but also those that typically don't cause vision impairment, but are the leading reasons for care-seeking behaviour, and really due to this reason, lead to personal and financial hardships of individuals. So these conditions are very important to keep into consideration in terms of effective planning for eye care services. If we look at vision impairment now, and going off the results from the report, what we can say is at least 2.2 billion people today have a vision impairment, and we really need to put the emphasis on at least 2.2 billion. This is based on data that is available to us, but we know that this is a conservative estimate, and we know that many more people globally have vision impairment due to refractive error, for instance. Of these 2.2 billion, we know that at least, again, 1 billion people have vision impairment that could have been prevented or is yet to be addressed. Of those that could have been prevented, we have a number of conditions such as diabetic retinopathy, glaucoma, that if detected early enough, obviously these individuals could have their vision impairment prevented. And then we have a huge number of people with unaddressed near or distance refractive error causing distance or near vision impairment, and nearly 65 million people with vision impairment due to cataract. So one of the other challenges is that really we have very little knowledge in a number of areas, and one particular area, and this goes back to my point on the emphasis on the term at least 2.2 billion. Due to limitations in the way in which data is currently collected from population surveys, we have a very good understanding of the unmet need for care. However, we don't have a good understanding of those who already have glasses to compensate for their refractive error, but these individuals obviously need ongoing care. Therefore, sort of health systems are required to sustain care for these individuals, and therefore it's very important for us to start now collecting systematic data on the met needs so we can better plan for our services. Another gap in data is related to health systems and implementation research. So we see that the vision sector and eye care is a very high potential for benefiting from technological advances, and to ensure that these technological advances really impact on the clinical care of patients, we really need to build stronger health systems and implementation research globally. As I mentioned before, those conditions that do not typically cause vision impairment but are very important, we have little knowledge globally of the magnitude of these conditions. And lastly, even in countries with very well-established health information systems, they don't regularly collect data on vision impairment, eye conditions, and their determinants, which consequently leaves decision makers with a lack of information to be able to identify the needs and allocate resources optimally. Obviously, we also have issues with access and barriers to care. The utilisation of eye care services varies quite significantly and is uneven globally. There's many factors that play a key role in this, and we've got the 3 A's here: availability, accessibility, and affordability. When we think about availability, obviously a shortage of trained human resources, including optometrists, is one of the greatest challenges to the availability, to increasing the availability of eye care services. And several factors really accentuate this problem in terms of suboptimal distribution of services, for example, in rural areas of many countries, and issues with coordination and retention of eye healthcare workers is also a challenge that is being faced by the sector. In terms of accessibility, we have, for example, gender, socioeconomic status, and even perceived costs of care play a key role in barriers in people accessing care. And we know that affordability and the direct costs and indirect costs of accessing care and utilising care is a major barrier. And we'll go into this in a little bit later in the presentation. So due to all of these reasons, we see that really there's large inequities in terms of access, but also in terms of vision impairment. So it's estimated that the prevalence of vision impairment is 4 times higher in many low-income regions than it is in most high-income regions. Even within countries and even within high-income countries, there are very high-risk groups that have been identified quite consistently in the literature, including those from rural areas, low-income, women, older people, Indigenous populations, ethnic minorities, and people with disabilities. So we think, how can this be? And in such a mature field of eye care, where we have a very strong public health epidemiologists, very unified and coordinated advocacy, we have technology and innovation, as mentioned before, and we also have effective and cost-effective interventions that address the continuum of care for the majority of eye conditions that are very feasibly implemented when compared to many other interventions from different health conditions. And one of the reasons why we are still seeing, as Alarcos mentioned before, these stark inequities in access to care and large unmet needs is a lack of integration. So in the eye care sector, there tends to be vertical programs that run in parallel to the health system. There is also, tends to be a lack of coordination between the public, private and NGO sector at times. We have an uncoordinated and unregulated workforce in many countries. In collecting some data from a number of 24 countries, we see that optometry, as an example, as a profession, is not recognised in 8 countries, and there's no educational requirement, which of course can have a substantial impact on the quality of care that is provided. We also, as mentioned before, eye care is not well integrated within the health information system. So moving forward now and looking at what are the key areas of action as suggested in the World Report on Vision. One of those is really advancing universal health coverage through eye care, which I'll touch on first. And the second is implementing integrated people-centered eye care. So in terms of universal health coverage, we know that this refers to the access, people being able to access the continuum of care all the way from health promotion to rehabilitation that is of good quality, so to be effective, and people can access it across the life course and it doesn't expose them to financial hardship. So to address many of the challenges, particularly those related to inequities of access, eye care really needs to be an integral part of universal health coverage. And there's 3 key points on the slide here. I won't go through them in detail. These are just key messages based on evidence and knowledge that are important for policymakers to consider. And to really achieve universal health coverage, countries need to advance in 3 dimensions as represented by the cube. Firstly, the services need to be expanded. Secondly, more people need to be covered. And thirdly, out-of-pocket payments really need to be reduced. And one of the areas of work now that we're focusing on in the Vision program, together with our collaborations with external experts and lots of internal programs at WHO, is the development of a priority package of eye care interventions, which is evidence-based and includes the resources in terms of the health products required and workforce competencies required for their implementation that really can be used by countries and country planners to implement eye care at all service provision levels. So this tool, once finalised, and we hope to have finalised the first priority package of interventions next year, then this tool will also be incorporated into the Universal Health Coverage Compendium, which is a WHO tool that includes interventions from all health program areas at WHO, which will also work to integrate at the government level. Also, I think it's worthy of mention that there are 2 indicators, and really important indicators, that are particularly important for optometrists. The first one being effective coverage of refractive error and cataract surgery. We saw that 1 billion people have vision impairment or blindness. At least 1 billion people have vision impairment or blindness due to these 2 causes. So, and we know that these interventions to address these causes of vision impairment are very feasibly implemented compared to other health areas. So these indicators are not just relevant to eye care, but also to universal health coverage in general. And for this reason, they're currently being considered for inclusion within the WHO index to monitor universal health coverage. And we will be working over the next year again with our external partners and drawing on expertise externally to really focus on setting targets for these indicators and developing tools that can help countries plan and cost to achieve these targets. And the last thing I wanted to mention was integrated people-centered eye care, which is really the key premise of the World Report on Vision. By definition, we can see on the screen that eye care, integrated people-centered eye care, really refers to eye care that is managed and delivered so that people receive the continuum of care to address the spectrum of eye conditions, is coordinated, and it recognises people as beneficiaries of the services. So the 4 key pillars of integrated people-centered eye care are listed on this screen, and just to very briefly go into each of them. The first is really empowering and engaging people and communities. So this is obviously important for particularly underserved populations through raising awareness on the importance of early identification and prevention of vision impairment, but it also involves really simplifying access to care to underserved populations through the use of technological advances. The second, which is very important, is reorientating the model of care towards building a very strong primary care. We've seen examples of success in this regard in the eye care sector in some countries, and it just shows that when sufficiently resourced, primary health care can meet a large number of people's eye care needs. And we can think about conditions and assessments and interventions such as diabetic retinopathy screening when appropriately resourced, the case identification of conditions like cataract, and diagnosis and management of some conditions that are very frequent, such as conjunctivitis. The third pillar in coordinating services within and across sectors is obviously really involves reinforcing linkages between eye care services and relevant programs such as diabetes and maternal child and health, and also reinforcing linkages between related sectors such as education, labour, and also the private sector. And last but not least is creating an enabling environment, which really involves, and a key pillar of this is ensuring integration of eye care in national health strategic plans. If eye care is not included in national health strategic plans, then it will often get left behind and won't be funded optimally. So this also involves ensuring eye care workforce planning is included in broader health workforce planning, and to address many of the challenges, including, you know, a shortage of highly trained optometrists and ophthalmologists globally, that it's important to ensure that a competency-based care approach is adopted where needed. So these are the key recommendations of the report. Each of these recommendations has a number of sub-aims that really helps to operationalise the integrated people-centred eye care and improving eye care through universal health coverage. And the WHO is in the process at the moment, and has many plans to develop tools to help countries, support countries in the implementation of these recommendations. So I will leave it there and pass back over to Alarcos very quickly.
Yes, thank you, Stuart, for that overview on the World Report. And actually, you could still put this slide in the screen, because I think, and if you can go to the previous one, look, these are the recommendations of the World Report on vision. And actually, there is a risk with World Reports that they remain in a World Report without having any impact. And that is really what we need to avoid. What we need to do now is really to take on these recommendations and really implement them and give them life and define strategies how we will implement them in our own country, in our own setting, in our own context. In order to show you that this World Report and these recommendations have already had an impact in member states, in countries, in ministries of health, I want to announce today that we have an upcoming resolution at the next World Health Assembly. This will imply that 194 member states will endorse all these recommendations of the World Report on Vision, and we commit themselves to implement them and really to promote integration and people-centered eye care as it is described in the report. So for us also is an opportunity to be here with all of you to really reemphasize this call. We need you, we need all of you to support ministries of health, support your countries in order to implement those recommendations of the World Report, what your ministries of health will very soon commit also to endorse. And this is also the call from WHO and from our Director General at WHO, who at the launch of the World Report on Vision mentioned, we don't have any choice. We need to take on this challenge. We can really not allow that there is still 1 billion people around the world living with vision impairment when this vision impairment can be addressed or could have been prevented. So we need really to tackle that, and we need the work of all of you for that. And with these words, we would like to finish this presentation. Thank you. And back to you, Kristan.
Sorry, I was trying to get my microphone back on. Thank you so much for the presentation, Alarcos and Stuart. A great wrap up and summary of the World Report on Vision, this large undertaking. One of the things that I would love to say is congratulations for these 194 member states. I can't even imagine the work that it takes to get that many people aligned on a specific report. It's amazing. Congratulations. The implementation work obviously will be a very interesting part of this going forward. Our next speaker is Anurag Hans. And one of the things that I would like to share is that at the same time that the World Health Report on Vision and this report that Essilor is going to share today, these two were working separately and came to very common conclusions. And one of the things that I would like to say is that when we start to look at changing the landscape of vision, it will require public and private sector organizations to work together. There's no way that one or the other can do this alone. So I have the privilege of introducing you to Anurag Hans. He's Vice President of the Base of the Pyramid Strategy, Innovation, and Market Acceleration at Essilor. He will be presenting to you the Eliminating Poor Vision report that was published in September of last year by Essilor. Thank you.
Thank you, Kristan. And can you hear me, Kristan?
Yes, I can hear you. Thank you, Anurag.
Okay. Thanks, Kristan. And thank you, everybody, for joining this session. It really makes us very glad and very happy to see such a large participation, and very happy to be sharing the findings of the Eliminating Poor Vision report. First of all, a big thanks to Stuart and Alarcos for a great, summarized presentation on the WHO report. It's a great effort, and as Kristan said, we are very happy to see that there are a lot of areas of complementarity, and we hope that after this session it will just further compound it. So,
Anurag, will you be sharing your screen?
Yeah, I'm doing it right now.
Okay, awesome. Thank you.
Can you see my screen?
Yes, we have it.
Okay, great. So just to give you a very quick background, I'm assuming that most of you who are on this call know Essilor. So we're the largest manufacturer of ophthalmic lenses, and we are a company which is driven by our mission to bring good vision to everyone, everywhere, with obviously a focus on refractive error, because that's our domain. We about 2 years back, we set ourselves the big ambition of being able to orchestrate the collaborative effort of eliminating poor vision in a generation. So we set ourselves the daunting target of saying that can we bring together all parties concerned to create actions and create systems to eliminate uncorrected refractive errors by 2050, and that was the genesis of this report. What we wanted to do through this report was to, first of all, have a common definition of success. How would we say that uncorrected refractive error as a public health issue has been addressed by 2050? What would be the measures? And therefore, what would be the actions which would be needed for us to be able to say that with confidence by 2050 or hopefully before that. So this report basically defines the scale of the vision care crisis as it is right now, with, as I said, a particular focus on uncorrected refractive errors. And then also to move the time horizon forward by 30 years and see where would we be in 30 years if no action is taken. And if we want to take action, then what should be the key priorities and what should be the investment areas that we collectively as a group can look at to take care of the URE problem. So the report recommends a partnership approach. It focuses to bring about widespread systems change. And in fact, as the WHO report was being presented, I could already see that there were a lot of areas which are very consistent across the two reports. So addressing public health systems, entrepreneurship, devising frameworks through which private sector and public sectors could work together, and obviously realizing the fact that even if we are able to create sustainable models for bringing vision care to the people who need it the most, there will always be a role for strategic philanthropy. Just to give you an overview of the team and the kind of the people who worked on drafting this. So McKinsey & Company, which I'm assuming that a lot of you would be familiar with. So their global health team, which in the past have done similar work around eradication or elimination of global health causes and creating roadmaps for issues such as HIV or malaria. Those were the same people who came on board to look at the area of uncorrected refractive error. So this was a very unique context even for them, because this was not a health issue which could be eradicated. This was, and I'm specifically talking about refractive error here. So this is a health issue for which you need to create systems to sustainably address the need every 2 years or every 2.5 years. So therefore, they could not think in using the same frameworks that they would have generated in their past studies. They had to think afresh and take a very different approach. So they provided the analytical support for the report, interviewed over 100 experts across eye health, academia, and program implementation. So I won't spend a lot of time on this slide, but everybody on this call is familiar with the fact that uncorrected poor vision is probably the world's largest unaddressed disability, with 1 in 3 people affected by this disability. 90% of these live in the developing world at the economic base of the pyramid. That makes it all the more difficult to set up these sustainable systems that I was talking about earlier. Now, uncorrected poor vision has been estimated to cost the global economy $272 billion in lost productivity every year, which basically means that if we address this issue, we will add at least $272 billion to the world economy every year. And if we don't do anything, so by 2050, over half of the world's population may be afflicted with myopia, with drastic long-term health implications. So that's something which further prompts us to take action right now rather than wait for later. At this point, before we even share the overall findings of this report, we would like to give a very broad, develop a very broad understanding in the group of why some numbers could look the same or some numbers could deviate. The difference basically is the approach of looking at impairment versus need. So WHO in their report and their work have quantified vision impairment due to refractive error based on a less than 612 visual acuity cutoff, which is the classical sort of definition of it takes into account the limitations that public health systems may have. On the other hand, this report estimated the total number of people suffering from URE in 2018 as 2.7 billion people. This was based on a 6/9 visual acuity cutoff, focusing more on a need-based model, because we believed, and also the health experts who worked on this report believed that individuals still battle to see at distance with a 612 visual acuity, and it was if you start looking at their ability to work or learn, it can still be impaired. And then so that's the broad sort of context of why some numbers could be different across WHO report and this report. But essentially, if you look at these solutions, and if you look at the need to create these sustainable systems to take care of the need, the difference in numbers doesn't really matter. What needs to happen is the creation of these sustainable systems. So just to set the context, when we look at now, and 2018 is the year in which the analysis for this report was done. If you look at this, the current context, and you look at how the world would be in, let's say, 2050, we see some very interesting patterns. So so some patterns around population growth. Not surprisingly, the developing economies would grow by 34%, whereas the developed economies would grow only by 7%. Similarly, if you look at how the world economy will grow in terms of trillions of US dollars, you would see that the developing economies would add far more to the world economy as compared to the developed economies. So that further accentuates both the need and the importance of focusing on an issue such as uncorrected refractive error, specifically in the developing economies and the BOP contexts. So this chart gives the headline findings of where we are in terms of refractive error, and then looking at the uncorrected refractive error portion of that, and what would happen 30 years down the line if nothing changes, if we do nothing, if the industry maintains its focus of serving established markets, using similar channels, using similar approaches, and using similar products. So as we stand today, out of the 7.6 billion odd people in the world, the report estimates that there are about 2.9 billion people who need no vision correction. About 2 billion people form what we call the organized vision correction sort of industry or system right now. So 2 billion people who have refractive error and have the mechanisms, the purchasing power, or the awareness and access to get access to a pair of corrective spectacles. 2.7 billion people live with uncorrected refractive error, and what further complicates the situation is that 90% of them live in developing markets at the BOP. Now, if we move forward 30 years, and as I said, if we maintain the current approach, the world population would have moved to approximately 10 billion people. Out of that, 3.2 billion would need no vision correction. 3.4 billion would have access and awareness and the affordability to get access to correction. But 2.5 billion people would still be living with uncorrected refractive error, with three main barriers: affordability, affordability, awareness, and access. Now, the interesting bit which came out through this analysis was also that there is this big chunk of about 700 million people who would continue to live with uncorrected refractive error, not because they can't afford the products and services, or that they're not aware, but only because they are not able to access vision care services and products, because they live in areas where probably there is no way or mechanism through which they could access an eye exam or a simple pair of spectacles. So based on if we look at the split of refractive error by type, obviously myopia would dominate the refractive error landscape. By 2050, we estimate about 4.5 billion people would be myopic. In this chart, I would just like to explain how they have categorized. The report categorizes the conditions. So myopia is basically all myopia, and similarly hyperopia is all hyperopia, which basically means hyperopia and its overlap with other conditions. Whereas presbyopia and astigmatism are pure presbyopia and pure astigmatism. But what really comes out, the broad takeaway from this study was that the number of refractive error cases would grow between now and 2050, and therefore the need for us to take action now is more important than ever. But even though the size of the issue and the size of the ask is big, we can solve this issue. So in thinking about how to go about solving this issue, the project team looked at almost all the initiatives, all categories of initiatives which have proven successful, proven not successful in the past, and start to look at, okay, which initiatives and models are most promising and therefore need to be invested in for this issue to be solved by 2050. So the broad findings of the report is that if the world collectively decides to invest $14 billion from now till 2050, you could create a world which is free from uncorrected refractive errors. Now, $14 billion on its own might sound like a big number, but in the overall context of global health spending, it's virtually a very small percentage across 4 areas. So the first one is the need to create sustainable access points. Creating access points, either optical shops run by entrepreneurs, or vision centers at hospitals, or mobile solutions which are providing access to bring access to rural communities. And then looking at about 4.5 billion of the 14 billion to raise awareness, about $700 million for innovation, which will need to be front-loaded, which will need to happen now for it to have effect till 2050, to create affordable products, to create more effective screening equipment, and still about $6.2 billion to fund subsidized and free services. So these were the broad actions. So if we are able to take actions across these 4 areas and invest, as the report suggests, we can solve this issue by 2050. So very quickly, what does each of these areas mean? So the report predicts or calculates that we need to create about 1 million new sustainable access points, which will be able to equip 90% of the population in need. And it could be full refraction service points, or it could be points which are only offering presbyopic correction, but approximately 1 million new sustainable access points. As I said, about 700 million for innovation, 2 broad areas, investment in screening tools that require less operator training are easy and affordable to operate, and tools to accelerate the scale of digitalization, which can bring services faster. The third point is on raising awareness to drive demand and to drive the uptake of services, and also to drive investment in new and existing services. And then finally, the funding of subsidized and free services. The interesting bit is that if we are able to create 1 million sustainable access points, you could use that network to drive 50% of the philanthropic and subsidized services as well. So that would become a very efficient channel for you to reach the poorest of the poor as well. So those are the 4 areas, and as I said at the start, so we at SLR, so we are driven by this ambition of to be able to eliminate poor vision by 2050, and we really believe that if partners from all sectors come together, we can eliminate poor vision by 2050. Thank you.
Thank you, Anurag. Very good information about this report. I am going to, without sharing my screen, go ahead and turn this over to Kovin. We're starting to run a little behind. Kovin, to facilitate the Q&A, if you can maybe cut it to about 10 minutes, then we'll address the other. So thank you.
Okay, thank you, Kristan. Some of the points have been made, so I'll try and reduce that. Let me just share my screen with you so that you can see, and just let me know if you can see.
I see your screen, just not the presentation. If you'll share it in a window, Kovin, and then select the presentation, it should show up fine. There you go. I see it.
You see it?
Yep,
okay.
Thank you.
Let's also look at, sorry, let me know people are battling. So can you see that now?
I can see it. If you'll put it in presentation mode, will be great.
Okay.
Thank you.
Right. So I'm going to try to very quickly look at, in the context of this report, the changing landscape of vision care, what we need to do in order to address the challenges that we are confronted with. I'm going to try and bring it home because we know that in Africa that the prevalence of distance vision impairment in low and middle income regions, which is basically Africa, is estimated to be 4 times higher than in high income regions. And then if we look at unaddressed near vision impairment, for example, we have figures of 80% and above, whereas in the developed world, that number is as low as 10%. So simple thing like getting reading glasses in Africa is a major challenge for us. We know that the current environment of eye care in Africa is and this is globally in many ways in the developing world, is there's a lack of relevance in public health systems. We have a team approach that's lacking. Human resources, as we know, has been flagged already, is a major challenge. And we have had pockets of successes. I'll talk more about that as I go through the presentation. But let's just look at the public and private sectors, because we need to address the whole ecosystem if we want to truly address the needs. The public sector is under-resourced, and in many cases, eye care is not a priority. When we've got HIV, malaria, etc., it becomes very difficult for eye care to be a priority. Private sector is underdeveloped in many parts of Africa and is concentrated in cities. And this applies both for ophthalmology and optometry, but it's more so in optometry. So let's look at the human resource challenge. We know that we have a limited number of optometrists and ophthalmologists. We have challenges in producing eye care personnel because we lack training institutions, the length of training, lack of teaching personnel, etc. We have a maldistribution of optometrists and ophthalmologists, again, concentrated in the cities, and also in certain countries like Nigeria and South Africa have good numbers and other countries have lesser. And the scope of training that we're looking at is often not matched to the local needs. In some cases, people are trained more broadly than what is needed, and in other cases, they are undertrained in terms of the need that exists. Good news as well. We get of success. This is a demonstration of our ability to contribute as an IK sector within the public health system. We know that many NGOs and governments have partnered, like One Sight, Sight Savers, etc. We've worked with vision centers, the Brian Alden Sight Savers, Light for the World Alliance in East Africa that reach close to 5 million children with support from Standard Chartered Bank. We know that there have been these pockets of successes. But no matter how much success we've had thus far, there's a lack of scale. And that's our fundamental challenge. There's a small but active group driving access in Africa, both in governments and non-profit sector, but scale is eluding us. And I think we need to consider that as an important part. Alarcos mentioned integration, and we know that integration is a big challenge, but diabetes has shown that integration is possible. We have a situation where, as diabetes has increased in Africa, many hospitals, you find the ICAP team is now working with the physicians, the optometrists, with the ophthalmologists. So these are changes that are happening that are going to enable our reaction to some of the key things that the World Report or the SLO report has identified. School eye health has become a major item on the global health and education agenda and on the child health agenda and child rights agenda. And that has been an enabling factor. There's much more investment happening in that sector. There's standard guidelines that NGOs listed there have produced, but they're also much more focused on funding child eye health programs. So this is one of the areas that we can actually exploit to look at how we can achieve some of the demands of these two reports that we've heard about today. But do these reports help? Do they make a difference? Is it really worth it? Now, having served on the editorial committee of the Global Action Plan and now the World Report, I can tell you that the initial Global Action Plan was a big fight to get certain things in. Just the mere mention of optometry as a separate section was a big debate. But it led to many things. The Global Action Plan was used by the IAPB and partners in Africa to get optometrists employed in the public sector, to get focus on training of optometrists, etc. So despite all those issues, it was very successful. The World Report, on the other hand, is a much more comprehensive, inclusive approach, which talks about integration, is adopting a systems approach, and is in fact can be more amenable to addressing the issues that optometry can contribute to specifically. And we know that they both identify that URE is the second leading cause of blindness and the leading cause of moderate to severe vision impairment, which in itself becomes powerful tools. Both have identified myopia as a major driver, but let me say that even though myopia may not be high as China or the US in 2050, the lowest would be East Africa at 23%, and the highest would be Southern Africa at 30%. So we starting on a low base in Africa, but we will have a significant growth in myopia, and that trend is going to catch up with us. We've repeatedly heard from the Global Action Plan and other programs about a systems approach, or let's address the entire ecosystem as we address eye care. Now we find that universal health coverage and integrated people-centered eye care are components that actually are going to force us to adopt a system approach, not to just have vertical programs. Now, it doesn't mean you can't have independent programs, but even if you're having programs in the private sector, we're going to have to look at how those programs can refer or receive referrals from the private sector, from the public sector. Anurag talked about $6.4 billion in free services, and that's to address the whole ecosystem. A lot of that can happen through universal health coverage, and there needs to be this coordination between the public and the private sector. And if you look at some of the discussions around universal health coverage, it talks about public-private partnerships and looking at how those things can be developed. So I know many of the people here are private practitioners. Going forward, there's going to be an absolute need for us to look at how the private sector can work closely, to look at models that can happen where the private sector can subsidize the poorest of the poor who are currently being catered for in the public sector. In terms of human resource development, we heard about the number of refraction access points that are needed. And we all know that we wouldn't even come close to meeting that targets with our current trajectory in Africa. Prior to COVID, but even more so during COVID, even in the US, technology has stepped to the salvation of practitioners. Telerefraction has become, teleoptometry in the US has become a big part of reaching access in rural communities, right? We need to look at in Africa how we can use telerefraction to connect primary vision care providers to optometrists. In that case, in that situation, we addressed the question that Stuart raised about ensuring we create access while maintaining quality. Now, we know neurology does this, other telemedicine programs occur. We need to be creative to look at how eye care can step up and use this. We know in a lot of cases not viable for optometrists to set up practices or to go and work in small clinics in deep rural areas. This could actually solve some of those issues. We have experiences now in India where our BOP team has been conducting a pilot study, and there we've worked with 600 technicians and 115 optometrists to ensure this occurs. And the outcomes of that is very positive. Because of time, I'm not going to go through all the details, but I would encourage you to engage us and others about the potential to create access through telerefraction. We know that when setting up programs, it doesn't automatically lead to access or to uptake, sorry. And in many cases in Africa, we've had that experience. Even though we know the need is there, we go in and set up programs, people don't come forward. There are a lot of beliefs, there are very other stigmas that exist that prevent this from happening. So therefore, I think that health promotion, which has been flagged in both the reports, are absolutely important. And we need to invest in awareness campaigns in communities to make sure that the messaging is out there. And refractive errors in particular, which optometrists should take the lead on, is a good way to actually recruit people even for cataract, glaucoma, etc., because it's not a threatening way to get people into clinics. You're not talking about surgical interventions, etc. The Fred Hollow Sight Savers Vision 2020 and the SLO Vision for Life Foundation conducted a program in India, which is called the See Now campaign. And that campaign showed a 38% increase in people attending screening programs as a result of using a celebrity, Amitabh Bachchan, in that process. So we need to use various aspects to look at that. Because of time, I'm not going to say too much about advocacy and policy change, but except to say that if we want to become part of UHC, we want to ensure that we push a systems approach to addressing eye care needs in Africa, we need to have a clear advocacy strategy and ensure that the appropriate policies are implemented. We've seen the benefit where in Kenya, our school IELTS team has started an income generating approach to ensure sustainability. Many people said it won't happen, but that program now is working well. But the Nakuru County in Kenya signed a MOU with us to do that. And most importantly, it has brought optometrists into the school. It created jobs for them. It's created opportunities. And what it is doing is it's driving access without a dependence on funding only. And such models can lead to a scale up in Africa if we have a combination. And the poorest of the poor within those programs are supported through philanthropy. So advocacy, policy change is very important, because without the policy, we won't be able to do that. And people then pay in that program through M-Pesa, which is a mobile linked solution, which takes me to the technology issue. And again, very quickly to say, we need to embrace technology. We can see the mobile technologies that are emerging as a challenge. It's going to replace us. Or we can look at how through telerefraction, through other programs, we can actually embrace technology and ensure that access and quality of care is brought to the market. The reality is that if we don't do that, we've seen people emerge periodically with a mobile phone and say, I've got a solution. it's a quick solution. Most of those solutions haven't gone anywhere, but those will continue to happen outside the system. And we've heard from the WHO the importance that for the public, private sector, and all of us to work together and to integrate the processes that are happening. So we should leverage the economic scale as case, because we know that the governments sit up and take notice when we talk about the dollars, and you've heard about the numbers. And more recently, the myopia paper we did show that $244 billion in lost productivity occurs just for myopia. And if you look at the projection of myopia, there is a strong economic case to be made. And I think on the continent, we need to raise this. And therefore, our engagement may not be just with the health ministries, but even finance ministries. Post-COVID world is going to be different. Unemployment, reduced disposable income, health systems that are under-resourced. We need to be prepared to think differently about where we go. And we have now 2 reports that have given us some indications of both the problem and the possible solutions and directions we should go in. So finally, I'd like to say that we need a comprehensive approach from optometry. It's a response, and the same applies to ophthalmology as well. Both public and private sector within a systems approach. We should support public-private partnerships. We should be supporting access for the poorest of the poor through philanthropy and government-supported programs, etc. But optometry needs to embrace technology, which I've spoken to, needs to take the leadership role in uncorrected refractive error and myopia, because it's a travesty of justice that people cannot get access to such a simple solution. And I think history is going to judge optometry very harshly if we don't take on this challenge and at least come close to dealing with it. We need to look at both entrepreneurship and empowerment, as well as public sector engagement. And we need to talk about the healthcare team. We can't have programs in silos without referral pathways, etc. So that, because if we do, we will compromise the health and safety of our patients. But at the same time, we cannot have the kind of models we have that are cocooned and refuse to look at rural solutions and bringing in technology, etc. Together, if we do this, most probably we can eliminate poor vision by 2050 in Africa. Thank you. Sorry, I rushed through it. I know time is of essence. Kristan, are you there?
Yeah, sorry, I was having a hard time getting the microphone turned back on. Thank you for your presentation.
Apologies for rushing everyone again, because I just...
No problem at all. And we appreciate seeing what the bridge looks like and what the real impact to Africa is at this moment. I'm going to, let me try to see if I can share my screen again. We're going to move to the Q&A. If someone still has their mic open, can you please turn it on at this moment, because I'm getting a lot of feedback. What I'd like to do is go ahead and go to the Q&A. I have multiple questions and statements within the chat. If you have other questions or statements that you would like to make, please feel free to send those to us. I am not sure that I'm going to be able to see them now if I'm sharing the screen. Actually, I'm going to stop sharing the screen so I can look at the questions in our chat. It will be easier that way. So first off, many comments coming about the idea that optometry services, there's challenges at the training level. And what are we going to do to, as an organization, as groups of people, address this training level differential? There's a major problem because training is the foundation of professionalism as a tool to be used to tackle the problems that we have highlighted in this meeting and others. How do we address that? And I'd like someone, maybe Ayukatong, maybe this is a question for you. Maybe it's a question for those of us who've already presented.
Hi, Kristan.
Yes.
Thank you. Indeed, there are a lot of challenges in terms of the training due to how optometry is being recognized and regulated at various countries in Africa. However, I think the AFCO board has been working very hard with the education committee so that we could see how curriculum could be harmonized. That should be the first step that we need to take. If curriculum is harmonized, then we could see how we could spring forward on that. And there is also the challenge of institutions or countries that optometry is not well recognized and regulated. We are working towards that. We've had some communique with the World Council of Optometry. We want to know the present situational analysis so that we can support those other countries whereby optometry is not recognized and it's not regulated, so that we can get the public sector, we can get the leadership and the government to be involved to see how we can push forward optometric practices and give quality and equitable eye care services to our communities. I don't know, probably the other presenters could want to add something on what I presented. Thank you.
Would anyone else like to add anything to that?
Can I just say that I think in the interest of time, let us move on to the next question, but to just flag that one of the points that Stuart made about competencies is very important. And I think a competency-based approach, which the WCO has a competency model, which allows for differential training, has been out there. I think maybe partly why it hasn't got legs is that we haven't been able to link it up to a proper system. And maybe that's the big challenge for us to start looking at for the future. Thank you.
Great. One of the things that I would like to share is that we will take all of the questions that have been presented if we don't get to them today on this, and we will send you a question and answer document that we can ask our speakers to address your questions and then send it to you at the end. So the next question I would say is, it's really a statement and then a question. The successes with trachoma and other diseases like vitamin A deficiency was due to the community-directed intervention packages adapted and scaled up. So is it feasible to adapt the same type of increasing visual impairment due to myopia in low and middle income or low resource countries? Kovin, you might take this one, or WHO?
Yeah, let's give WHO a chance first, and then, because it'll be too optometry focused, and we'll end up anything on.
Actually, it is a very good question. Here is Alarcos, and it is actually a point out to a very important thing. What we need to take into consideration, and that is also something that Kovin has been emphasizing before, is that, of course, this could be, it was possible to scale up these interventions because they were completely integrated into a public health system, and in many cases also a commitment from the government and from the health sector to scale up those interventions. And I think it is a good approach, but again, without integration into services, I do not see that we could make it sustainable. At the end of the day, it is not only about provision of or doing an assessment of provision of glasses one time in the life of a person. It is really about providing and maintaining and sustaining those services. I think the have been also mentioned from the colleagues in terms of what are the steps of making and create sustainable access points and so on. All of these will depend whether we are really able to integrate to a system of care that requires coordination, collaboration, also with the private sector, but that has also a leadership and governance of the, from our point of view, of the Ministry of Health, also integrating and taking into consideration all the work that optometrists do at primary healthcare level. And I think there is, when moving forward and thinking of approaches we have, from our point of view, two options. Either still maintaining eye care as a separate sector, including optometrists and refractive errors care, as a parallel system, not really taking into consideration, not really making a priority, or we really try from the outside, taking into consideration of the momentum of what the data is saying, to really make the effort to integrate, to make it part of primary health care, and to make possible that services are sustainable. I think eye care is not a priority, but it has the potential to become of a priority, because everyone can empathize what does it mean to have an eye care condition of vision impairment and not have access to simple interventions like the provision of glasses. Thank you.
Thank you, Alarcos. The one other question, I think we're only going to be able to take one more, and then like I said, we'll take the questions, give them to the panel, and then we will address them as we go forward. Let me ask one more question to the panel. We have a question from Dr. Nadi. Gender disparity is one of the major issues faced, especially in most African countries. What are the actions that can be put into place to improve this? Because when universal health care coverage is expanded, we have to ensure that both gender needs are met. Can someone answer that question?
Empowering to seek services, that was also addressed by Kovin before. He put it in terms of health promotion. We would also put it in terms of health literacy, but it is really empowering and also promoting health literacy in terms of eye care, and that not seeing well is not something or the situation that needs to be accepted. The opposite, that there is something that can be done. And this can be also achieved through empowering women in general, but also from the perspective of eye care.
It's great. Thank you so much. Apologies for the fact that we've run short on time. It's about time to end the presentation. I want to say thank you to everyone who's joined. I'd like to give Ayukatong a chance to say a few closing words as well from AFCO. Just a quick note that if you would like to see more from the Vision Impact Institute, you can log on to our website at the address that's here on the screen, and also join us on all of the social media channels that you see here. And Ayukatong, would you like to say a few closing words?
Thank you, Kristan. Thank you all the presenters for the wonderful job you've done. And I want to seize this opportunity to thank all the participants. It is awesome. We were about 100 that took part in this. It shows how Africa is very excited and interested to disseminate this World Report on Vision, as well as the SLO eliminating poor vision documents, and see how we can implement it at our various levels. Please, you've gotten all the materials. Don't just go and sit. If you have feedbacks, try and get back to us and work together to see how we can get into the implementation phase. Thank you so much. Keep on doing the good work of quality eye care with equity. Thank you.
Thank you all very much again for your participation and for joining us. We will send you a follow-up email that will have a couple of pieces of information in it. One is a presentation that breaks down both the World Report on Vision and the WHO report, or the World Report on Vision and the Eliminating Poor Vision report. We also will send you the Q&A as promised, and look forward to future opportunities with you. Thank you again very much.
So, Kristan, sorry, before you leave, I'm not sure that everybody who joined came through your email. So some people may not have your email address. Do you just want to give it to people? Maybe put it on the chat part so that those who didn't come through that system, you can then communicate to them as well.
Yeah, I will put it on the chat right now, and I'll leave it open for a few moments so everyone can see it. Can you hear me, Kovin?
Yes, I heard you. That's great. Thank you.
Okay. Thank you again, everyone. I'm sending the email at this moment. If there are any other questions, please feel free to reach out to me directly.